and this IC is about the clinical cases of neuro-ophthalmology, which sometimes baffle us in making a clear diagnosis. And we will also be discussing the role of neuroradiology in making the diagnosis of these neuro-ophthalmological disorders. So I start with my case presentation. The first case was a 40-year-old female who was non-diabetic, non-hypertensive. She presented to us with the pain on the right side. It was a hemicranial pain, but was more focused over the periocular area, and it was there for 1 week. And 2 to 3 days following that headache, she had a double vision, and she didn't have any history of any systemic disorder, or she didn't have any symptoms of that suggests that she was a case of a migraine, and she didn't have any family history of migraine either. When we look at the past history of this patient, she had a recurrent attacks of pain with double vision that started from 2012 when she was 28 years old. And she had a recurrent attack sometime involving third or the sixth, and it was happening on either side. And like she had many attacks, and some of the attacks she showed to the ophthalmologist and sometimes to the neurologist. So we could have the medical records of these 4 case attacks only. But the rest of the attacks, as she knew they were always prescribing the same medicine. She took those medicine and got the relief, and some of them they were the self-limiting also, and some of the attacks spontaneously resolved over a period of 2 to 3 weeks. The investigation done at these past, when she had those recurrent attacks in past, the blood chemistry and the blood picture and the vasculitis profile as she was a young patient were normal, and even she had undergone CSF examination twice, and that was reported normal. The MRI done during those attacks, cranial and the orbital, and that was also reported normal. So she had the blood test, the lab test, and the neurological investigation, both of them were normal. So when we sum up the past history of this patient, she had a recurrent third or sixth happening on the right or the left side, around 6 or 7 attacks since a long period, for around 12 years. And the investigations and done at that time, not only the blood, the neuroradiology, and they all were normal. And she was always treated during these attacks by the steroids and analgesics. And these attacks resolved completely on the steroid treatment, and within a period of 2 months, and they were completely reversible without it leaving any neurological deficit. Mainly it was the 6 nerve involvement. And these are the imaging MRI of the cranial and the cavernous area done during those past attacks of 2012 and 15, and they were perfectly normal. There is no enhancement of the cavernous sinus lateral wall or the cavernous sinus lateral wall convexity. As we know, in some of these painful ophthalmoplegia cases, it can happen. So the recent attack, when she came to us, she had a right periocular pain, but was radiating towards the V1 distribution over the temple, frontal and the temple area. And 2 to 3 days following that, she developed double vision. So all the attacks which were painful ophthalmoplegia, they were very stereotype type of attack involving either the third or sixth, and there would be the headache preceded by headache, and that followed by any ocular nerve palsy, and that were short-lived, and they will be lasting only 2 months and responding very well with the steroid or analgesic treatment. So when she came to us, when we examined, she had a normal visual acuity. There was right esotropia, and there was a mild ptosis over the right side, which was not mentioned in the previous records. The pupil on the right side was smaller than the left, but the reaction was normal. The asymmetry was increasing in the dark. That suggests she had a sympathetic nervous system to the pupil supply is dysfunctional. And the fundus and the fields were normal. So we made a clinical diagnosis of painful right 6 nerve palsy with Horner syndrome, which together is called as a Parkinson's sign. And that localizes the lesion to the cavernous sinus. As we know in this diagram, that 6 is very close to the internal carotid artery and lies in the cavity of the cavernous sinus. And sympathetic postganglionic sympathetic fiber, they wrap around the cavernous part of the ICA. then leave it and run it, join the sixth nerve and run it for a short while into the sixth nerve. Then they leave the sixth nerve and go into the nasociliary nerve and enter into the orbit. So it's whenever we have this combination of clinical features like sixth nerve with the Horner syndrome, that specifically localizing to the region to the cavernous sinus. As we know, there is a long list of causes of painful ophthalmoplegia, but the commonest one I mentioned are Tolosah-Hunt syndrome, IgG4-related diseases, then sarcoidosis, vaginal granulomatosis, fungal infection, and neoplasia. Our patient's clinical examination symptoms and the clinical examination, or both of that suggested that patient have a ophthalmoplegic migraine, which is now named as recurrent painful ophthalmoplegic neuropathy. It used to be called as ophthalmoplegic migraine, but now it is called as a recurrent painful ophthalmoplegic neuropathy. So the clinical examination was very much suggestive of this last diagnosis. But the rest of the, like Tolosah-Hunt syndrome, we excluded because Tolosah has a recurrent attack, but not that frequent as our patient had. And secondly, the Tolosah-Hunt syndrome, sometime initially the imaging may be normal, but later on the imaging would always be showing the enhancement of the lateral wall of the cavernous sinus or the convexity of the lateral wall of the cavernous sinus. Sometimes there is soft tissue enhancement of the orbit, apex of the orbit. And IgG4 related, you know, in the patient usually have a paranasal sinuses enhancement on MRI, and the lacrimal gland enlargement, and infraorbital nerve thickening is also known, and they have a multi-system involvement. About that sarcoidosis, again, there is involvement of the your lacrimal and the parotid glands, and the seventh is more commonly involved in sarcoidosis. The vaginal granulomatosis, always there would be soft tissue imaging when you do the MRI, which patient never had in her previous attacks. It was a perfectly normal MRI. The fungal infection, again, there would be paranasal sinuses involvement. Is there thickening of the mucosa or the filling of the sinuses would be there. Sometime you may get normal sinuses with the enhancing soft tissue mass at the apex of the orbit, the cavernous sinus. Then only the biopsy can help, or sometimes the MRS studies, they can help you making other diagnosis. So the clinical examination, like history and examination, fits the diagnosis of recurrent painful ophthalmoplegic neuropathy in our case. So we did all the detailed investigation. As we know, it's a clinical diagnosis and a diagnosis of exclusion. So we have to investigate the patient thoroughly by lab and the neuroradiological investigation, and we found out that confirmed our diagnosis. And the main important out of all different causes which I told you about the painful ophthalmoplegia, the Tolosah-Hunt syndrome is the main differential diagnosis of this entity. And we know Tolosah syndrome is idiopathic granulomatous inflammation of the cavernous sinus or superior orbital fissure of the orbital apex. The MRI is always positive, and the changes what we get, always ask for enhanced, contrast enhanced MRI, because the plain MRI we may miss out this entity. And contrast will show the enhancement of the lateral wall with the convexity of the lateral wall, and the attacks are not that recurrent, and they are not short-lived, as if the patient had a duration of attacks were very short, but they are longer time, and sometime the recovery may not be complete, reversible. It might be leave some neurological deficit on recurrent attacks in Tolosah-Hunt syndrome, where our patient recover fully in all those multiple attacks. So we did the repeated investigation to make the diagnosis, and when we did our lab test and the neuro imaging was also normal. In even the cranial, we got the neck vessels MRA and do the lab investigation for sarcoidosis, X-ray chest, and MRI. We did the finer section of the cavernous sinus in the orbit, because sometimes some pathology to begin with, they are very subtle changes, and later on, when the disease progresses, the abnormalities they manifest more. So we repeated all, did the imaging of cavernous sinuses, orbit, the final cuts, and they all turned out to be normal. The MRA of this patient showed the right internal carotid artery was dilated in comparison to the left, and the carotid, it's a long segment of the ICA which was dilated, and even the posterior cerebral artery was very much close to third nerve on the right side. And even there was a posterior inferior cerebral artery loop near to the right sixth now in its prepontine when it runs into the prepontine cistern. So she had lot of vascular abnormality over the right side, and which can be the anatomical variation, and that were not responsible for the clinical presentation of our patient, because our patient was having these attacks third and sixth now on either side, not particularly over the right side. And any compression of this nerve, oculomotor nerve, because of these aberrant blood vessels, should be progressive. It would not be recurrent, episodic, as in our patient had, and it should not be recover over the attack. It should be a progressive one. So we also gave the patient a steroid, but the patient developed diabetes on that treatment. We switched over to her to Indocap, and she responded very well, as we have seen her previous attack that improved over a period of 2 to 3 months, but her pupillary asymmetry and the ptosis remained in this attack. So if we go through this entity, it's okay. So this patient is a recurrent painful ophthalmoplegia, but that is happening in adult patient, which was previously called as ophthalmoplegic migraine, and because International Headache Society renamed it as a recurrent painful ophthalmoplegic neuropathy. It's a rare disorder, more common in children less than age of 10 years, but in adults do get the cases. There are isolated case reports are there in the literature that this is entity happening in the adults. So diagnosis is a clinical, and it's diagnosis we have to investigate the patient fully to rule out other entity which I mentioned to you earlier. So pathophysiology is not clear of this condition, but it's supposed to be there are episodic inflammation of these ocular nerves, and which results into demyelination of this nerve, which later on remyelinate, and the nerve gets its function completely. So the diagnostic criteria laid down by International Headache Society are that the patient should have 2 attacks of the unilateral pain, and there should be the ipsilateral third, sixth, either isolated or in the combination, the palsy. There should be, MRI should be normal. On MRI, there should not be any paracellular, orbital, paracellular, or posterior fossa mass. Third is most commonly involved, and next to involved is the sixth, and the fourth is rarely. MRI is most of the cases are normal, but sometimes it show the enhancement and or the focal thickening of the nerve. We got the Fiesta scanning in our patient also, but we didn't find any thickening or enhancement of a 6 now. So majority of these attacks complete reversible. Their complete recovery is there, and that happens in a short time, like the weeks or months. So I move on to my second case. That's about a 25-year-old male who presented to us as a dull pain in the right eye, and that was happening while the patient was taking meal or he was chewing, and that was there for last 2 months. He didn't have any other neurological signs and the neurological symptoms. So when we examined, the acuity was normal, the motility was normal, and the pupil was slightly sluggish. So we thought it might be something in the visual pathway like optic nerve or a chiasmal or something. It might be there because the pupil is slightly before the retrogeniculate pathway. It must be there. The pupil is slightly sluggish reacting. Fundus was perfectly normal. Because of the symptoms, that was suggestive that this patient is an atypical trigeminal neuralgia or a atypical facial pain. And why I called it atypical trigeminal neuralgia? Because we know trigeminal neuralgia is usually common in V2 and maxillary and mandibular divisions. Our patient is an ophthalmic division, and those attacks are lancinating and electric shock-like pain lasting for a few seconds. But this patient have a dull aching and was lasting as long as he was chewing the food. When we did the field, what we found was the supratemporal quadrantenopia. That suggested that there must be a compression in the chiasma, that too from the inferiorly, because we know in the chiasma, which is slanting structure, the inferior nasal fiber, they cross anteriorly, while the supranasal fiber, they cross posteriorly, and the central part is occupied by macular fibers. So there is a compression of the chiasma from below that suggests it must be a pituitary mass which was growing. supraciliary and compressing the chiasma from below. But surprising thing, the patient has a clinical presentation as if he had a posterior fossa mass, because posterior fossa mass can present as a atypical trigeminal neuralgia when it compresses the fifth nerve in its prepontine or cisternal part. So the field findings were totally different. Okay, I just sum up fast. So field finding was totally different from the clinical symptomatology of patient. When we did the MRI, we found a cellular mass which was extending supraciliary, paracellular area, and even the retrocellular area, and compressing the fifth nerve, impinging, as you can faintly see the prepontine the fifth nerve in the prepontine cistern on the other side. And on the right side, it was impinged by the mass. So that was a pituitary adenoma which was extending so much in the different surrounding area, but it was the retrocellular extension which was compressing the pontine part of the fifth, resulting in a demyelination of the fifth nerve, and which resulted into the non-synaptic transmission of impulses. That means while he was chewing the impulses which are carried by second and third division, they were also spreading out because there was no myelin, and was stimulating the ophthalmic fibers also. So he was getting the pain during that chewing time. So surprising that this tumor was extending so much in paracellular area, and only the clinical manifestation of the patient's symptom has only because of retrocellular extension. That can be explained because it is mentioned in literature that third, fourth, and sixth cranial nerves, they have lot of elasticity. They can be stretched 4 times of their length, but still they remain functionally intact. And secondly, the motor fibers, they have a large diameter fiber and they have a good myelin sheath. So their demyelination takes, or their compression, they resist compression for a longer time, while the fifth is a sensory nerve, which axons are the very small diameter one, and they are very thinly myelinated. So demyelination, even on compression by a tumor, happens early in the fifth nerve. So patient underwent craniotomy, and it turned out to be a chromophobe adenoma. That's why the patient didn't have any endocrinopathy symptoms, only the visual symptoms and this fifth nerve compression symptoms were there, and that made this diagnosis difficult in this patient. Okay.